Good morning, family. It's pre-op day, so I'm on my way to our first appointment. We have 2 appointments today. The first one is where they're going to stick me like a push pin cushion. I'm getting my blood work done. I think I got to get an ultrasound done. I'm not sure what else is for the first appointment. But then my second appointment, we're meeting with the surgeon, the person who's doing my surgery. And she's just gonna check me out to make sure that I'm surgery ready. So yeah, come along with me while we get all that done. In the meantime, I'm gonna post exactly what I'm getting surgery for and exactly what they'll be doing to me during surgery and exactly what the surgery is. All right, see y'all later.
Ooh, yeah. Ooh, yeah. Ooh, yeah. It's my life.
I'm shopping, I'm cruising, I'm dining, you're losing.
Before your procedure, an intravenous line, or IV, will be started. You will be given antibiotics through the IV to decrease your chance of infection. You will be given general anesthesia to put you to sleep and block pain during the procedure. A breathing tube will be inserted through your mouth and into your airway to help you breathe during the operation. Your surgeon will make a small incision in or just above your belly button and insert a tube called a port. Carbon dioxide gas will pass through this port into your abdomen. The gas will inflate your abdomen, giving your surgeon more room to see and move the surgical tools. After your abdomen is inflated, a high-definition camera will be inserted into this port. Your surgeon will make additional port incisions for robotic instruments as well as for instruments used by patient-side assistants. An assistant will insert all of the robotic tools through these ports. Unlike standard laparoscopic instruments, these tools can rotate 360 degrees and have more flexibility than the human wrist. Seated at a special console, your surgeon will operate the robotic arms and the camera with joystick-like controls and foot pedals. A computer will translate the exact movements of your surgeon's fingers into precise movements of the surgical tools. At the same time, a high-definition vision system will provide a magnified 3-dimensional stereoscopic view of the surgical area. Your surgeon will locate your uterine fibroid and inject it with medication to reduce bleeding. Next, your surgeon will carefully cut around the edges of your fibroid and remove it. Your uterus will not be removed. The remaining edges of your uterus will be closed with sutures. At the end of your procedure, the tiny incisions will be closed with stitches, staples, surgical glue, or skin closure strips. After your procedure, your breathing tube will be removed, and you will be taken to the recovery area for monitoring. You'll be given pain medication as needed. You may be released from the hospital the same day or within 1 day after the procedure.
All right, so in the video, you seen that person's tumor was on the outside of their uterus. So my tumor is actually on the inside of my uterus. So they actually have to cut into my uterus to find the tumor and then remove it that way. So they're not just cutting the outside of it. They have to like cut into it to find it and then remove it. So it's a little more invasive than what it is on the video, but that's pretty much the procedure of what they're going to have to do. All right, family, so our first appointment is done. I got my blood work done and I got an EKG done. Everything looked good, But of course, I would get here and have a low-grade fever. Them dang kids done got me. But everything's good so far for the first appointment, so we off to the next appointment. That's at their different building. All right, y'all, see y'all later.
So you'll have like 5 different incisions, 4, one in the belly button area, one down on either side of the hip, and one kind of over on the side here.
Okay.
And that's where we're going to remove the fibroid
Okay.
from. We talked about needing potentially to cut them into smaller pieces,
yeah.
right? And so I'm just looking at your labs here. You know, that we don't think it's cancer. There's nothing to make us suggest or worry that it's cancer. Your age, the appearance of it on the ultrasound. But if by chance it was cancer, then that increases the stage.
Yeah.
So obviously if I see something and it's like, oh, that doesn't look right, then we're not going to do that.
Right.
It's just the sort of the uncertainty, but the chance of it being cancer in someone like your circumstance is like 1 in 7,000 up to 1 in a million.
Okay.
Your blood type and blood screen looks good. Yeah, your hemoglobin is low. Definitely. All right, so I think we'll just be very cautious at the time of surgery that if we maybe need to get some blood going for you, we'll do it sooner rather than later. We're not going to wait till you lose more blood.
Okay.
All right, so these are the consent forms. I'm just going to describe this in detail to you. So your name, Nisha. We're going to do an exam under anesthesia. So like when you're asleep, you'll meet my team.
Okay.
And we'll do an exam. The plan is to do this robot assist myomectomy, which is the little incisions, but an instrument that allows me to operate kind of like I was operating with my real hands, but therefore able to do this surgery, hopefully without having to make a big incision. Possibly, if either there's bleeding or inability for me to see and safely complete the surgery with the robot, then we might need to make an abdominal incision. Then you would stay overnight.
Okay.
Possible more extensive surgery. So we're operating in this very confined space. Your bowel's there, your bladder's there, the blood vessels are there. So it's my job to make sure I kind of talk about all the possible what ifs. So the purpose we're doing this is for your fibroid uterus. We're going to treat the pain and bleeding, hopefully by removing the fibroid. Major risks of surgery include bleeding, infection, pain. As I said, we're going to be kind of really watching closely because of your low blood count.
Okay.
As far as increasing bleeding risks, we use different medications to try and minimize that. Infection, we're going to use sterile technique to, clean your abdomen, as well as all the surgical prevention of infection. Pain, as I said, is to be expected. The big possibility to look out for would be injury to any surrounding structures, but because, like I said, your bowel, your bladder, blood vessels are all around there. So if there is anything that's injured, we'll want to repair that at the time.
Okay.
Alternatives, the interventional radiology, the fibroid ablation, those are 2 of the procedural things, but then you wouldn't be recommended to have pregnancy afterwards. And this says that you've had a chance to ask questions. You understand there's going to be some things that we can't predict, but to the best of our knowledge, these are the major risks and expectations. And otherwise, sometimes it is going to require on surgeon's judgment.
Absolutely.
Thing we know of for infection, the risk of getting HIV or hepatitis from a transfusion from like a blood bank supply is about like 1 in 3 million. So very, very low risk. Obviously, if we can avoid transfusion, we would prefer it.
Absolutely.
Because there is some risk. And even just the transfusion process itself, sometimes people can get a reaction.
Yeah.
But this would just be in this circumstance where we feel it's absolutely necessary. Okay.
I've been down that road. I've had 2.
You've had 2 transfusions before? Ooh. Because of
The
vaginal bleeding and miscarriage type things?
Yes.
Okay. Well, hopefully no more.
Right. Hopefully. Fingers crossed.
Yeah. Right. And I will take some pictures, so as long as my equipment behaves, I will be sure to show you what your uterus looked like before and after when I see you back for your post-operative visits.
Great.
And then our plan is I'll probably see you back about 2 weeks after surgery.
I think it's May 8th.
Oh, you already have it set up.
Yeah, we already have our appointments.
Any other questions?
Will I get a call just so I know exactly what
Yes.
time I need? Okay.
The night before.
Okay.
Our nurses will give you a call.
Okay.
And then, usually nothing to eat or drink after midnight. You'll probably be asked to come to the hospital, the Midtown Hospital, around 6 a.m. or something.
6 a.m. Okay. Oh, I do have a question. Would I be able to ride roller coasters and fly in July, or would that be too soon?
What are we now? April. Oh yeah, 3 months? I think so.
Okay.
I think so.
Okay.
Yeah.
My family planned a trip to Florida, and I'm like, I don't know if I'll be able to do that. And I was like, I have to ask at my appointment.
Yeah, I would say use your judgment. But
Okay.
Probably.
Okay.
I think probably.
Okay, great. They'd be happy to hear that.
All right. Well, let's. I just want to see if Danica or Maria need to talk with you any further. But other than that, I will see you next week.
See you next week. Thank
All
you.
right, you're very welcome.
Have a great day.
Okay,
family. So we are all clear for surgery. We are good to go. We will begin surgery next Thursday. I am super excited about this. This surgery is kind of life-changing for me, almost in a sense. So I've just been so eager and like ready to get it done and get it over with. I don't know, my brain has been so scattered today. Because it's just so much going on. But I think we covered everything. She said that my surgery is on the books to be the first surgery of the day, but I won't know for sure until the day before surgery when they call me and give me my call me and tell me what time I have to be there for surgery. But yeah, so thank y'all for coming along with me. We got a week left and we in there. I hope everyone has a great day. Holla at y'all later. Mwah. Peace out.
I'm cruising, I'm dining, you're
It's my
losing.
life and I'm working on my own rules. Wake up in the morning, chasing paper while they all snooze. Eat at Benihana's, then Bahamas for a long cruise. Living out my life, doing anything I want to.